of those tumors. Finally, targeted therapy options have expanded rapidly. So we have all these new FDA-approved agents, and we have many others in the pipeline that are the subject of current research. The side effects of these targeted therapies are distinct from the side effects of more traditional chemotherapy, but they do have side effects. And then finally, there's a lot of important clinical research that's going on right now, and this is really how we move on the entire field forward. So I thank you for your attention, and I'm happy to answer questions or defer questions to my colleagues and have a little discussion.
Yes, I was just curious, how do you sort out who is a good candidate for immunotherapy?
So it's a good question. As I've told you, it's a difficult treatment to undergo. So you'd love to have a way of figuring out exactly who's the most likely to respond, so you can give it to them, and then sort out the people who are unlikely to respond and spare them from the bother of having to do it. I actually think Dr. McDermott may be even the best person to speak in detail to that issue.
Okay, sure. Yeah, no, I think our ability to pick folks who benefit is limited. It's obviously a big question. We would like not to put people through the horrible side effects of things like IL-2 if we didn't need to. We've occasionally had people die from that treatment, so it's obviously very difficult. So we're trying to do research, trying to pick sort of pre-treatment markers of response, usually based on what the patient's tumor looks like, and some changes in that tumor that can be detected. So research is ongoing, but we've yet to confirm a really strong predictor of who should get it and who shouldn't. The reality is most people don't get it. Most people who do don't benefit. So we obviously need to do better. Our goal is not just to improve the way we select people for this treatment, but hopefully to come up with less toxic treatments that are more applicable to a broader group of patients. And there's some reason, I mentioned this sort of briefly in my talk, there's some reason to think that we might be able to do that. The treatment that I mentioned before, the ipilimumab or Yervoy, is producing long-term benefit in melanoma patients, working in it through the immune system as well. Does that work in kidney cancer? It might. We need to test it. But to test it, we need to put pressure on the company that makes it to develop it in kidney cancer. Because one of the downsides of all the, the great talk that Phil was giving, listing all the new treatments, is companies are a little bit more hesitant to develop new treatments in an area where now all of a sudden we have a lot of competition. So we need to push them, and we need your help to push them in those directions. Other questions?
May I comment?
Absolutely.
There's one thing that Dr. McDermott, I think, appropriately could not say as to a factor of selective hypothyroidism, because it's not scientific.